today's Grand Rounds, Department of Psychiatry, University of Louisville, June 2nd, 2022. I'm Robert Caudell, the program director, and I've been asked to introduce our presenter today, Dr. Justin Koo. Dr. Koo is a fourth-year resident in our program, preparing to finish here at the end of the month. He came to us via Loma Linda Medical School, where he had afterward done a transitional year and some anesthesiology training before seeing the light and coming to psychiatry. He's done a great job here with us during his 4 years in the program. He has accepted an outpatient program with the Veterans Administration in Los Angeles, where he'll be starting after completion of the program. We look forward to hearing his presentation today, and he's going to talk to us about cannabis use disorder. Thank you, and take it away, Dr. Koo.
Thank you, Dr. Caudell, for the introduction. I'm going to talk about cannabis use disorder. I have no financial disclosures. The objectives for my talk today are to first define cannabis use disorder, describe the pharmacology and pathophysiology of cannabis use disorder, review the acute and long-term effects of cannabis use, explore how cannabis use affects other psychiatric disorders, evaluate treatment options for cannabis use disorders, and to discuss the implications of increasing cannabis legalization in the United States. So I chose this topic because I believe cannabis use disorder is going to become increasingly relevant in the near future. 18 states have fully legalized marijuana for recreational use. And those are the blue states on this map. The green states have legalized the medical use of marijuana. The states with the D on them have decriminalized marijuana use. In the blue states, anyone over 21 years old can walk into a retail shop and purchase a certain amount of marijuana without a prescription. It's not too different from buying alcohol. Kentucky and several other states are still holding out, but I suspect based on the direction of our society that legalization will probably increase in the future. Increasingly more Americans support the legalization of marijuana. Just in the last 20 years, we've gone from 1/3 in favor of legalization to now 2/3. And when a majority of the population is in support of something, it's hard to keep it illegal. It's been tried before and failed. And now that alcohol is legal and ingrained in our culture, it seems impossible that it would ever be outlawed again. If marijuana becomes more broadly legalized, it's likely to stay that way. And like alcohol, it could become a drug that's socially accepted, despite whatever health and public safety consequences it might have. And for some people, marijuana is serving as a replacement for alcohol. The term California sober has been used to describe people who abstain from drugs and alcohol, with the exception of marijuana. And there's a few recent news clippings here that are describing this trend, with some couples having marijuana instead of alcohol at their weddings. And the marketing and aesthetics of recreational marijuana is noticeably stylish. On the left, you've got a shop in San Francisco, and the one on the right is in New York. Many of these recreational marijuana shops have this clean, modern minimalist design that you might see in upscale, trendy city areas. And it's pretty clear that they're taking design cues from these guys. There was a time where laptop computers were purely utilitarian items. They were clunky, made by a boring company like Hewlett-Packard or Toshiba, and not something you'd want to take to Starbucks as a fashion accessory. Similarly, cigarettes were sort of outdated among younger people, but Juul figured out how to rebrand them for a new generation. The cannabis vapes on the right are basically copying the design from Juul, and these look like accessories you might buy at the Apple store, and they really hide the fact that they're delivery systems for potent psychoactive drugs. If you haven't been to a state with recreational cannabis, the marketing of these products may be surprising to see. These vapes have similar color schemes and shiny finishes like the iPhones. These cannabis-infused seltzers look like White Claws, and they have some of the same flavors as well. And it's hard to imagine these beautiful gummy candies as being harmful. You've got grape, tangerine, cucumber, lime, and it says you'll uplift, unwind, and balance. So clearly the consumer is being primed to view these modern cannabis products favorably by mimicking familiar and attractive products that we're used to. So where is this all heading? Based on increased legalization, increasing societal acceptance, and slick marketing, one could predict that the prevalence of cannabis use disorder is increasing, and it definitely is. From 2001 to 2012, the percentage of people who used cannabis at all in the past year jumped from 4.1 to 9.5%. And the percentage of people who met criteria for cannabis use disorder nearly doubled from 1.5 to 2.9%. For more recent numbers, the CDC estimated that 18% of Americans used marijuana at least once in 2019. That's 48 million Americans. And they estimate that about 30% of people who used cannabis met the criteria for cannabis use disorder. So based on that, we're looking at maybe 5.4% of Americans that met criteria for cannabis use disorder in 2019, which is almost double the 2012 figure. Use is highest among ages 18 to 25, with men being nearly twice as likely to use compared to women. Use among college students is extremely common as well. A survey in 2020 showed that 44% of college students had used at least once. So across the board, the use of cannabis is increasing in the United States. And studies by the National Survey on Drug Use and Health have demonstrated an inverse relationship between perceived risk and cannabis use, where users who perceive that cannabis is less harmful are more likely to use. And they've demonstrated that this perception of cannabis as risky or dangerous has decreased. In a survey of adults in 2002, only 6% said that cannabis use carried no risk. By 2014, this was already up to 15% of adults saying cannabis carried no risk. So therefore, this should predict that cannabis use will continue to increase as the perception of risk decreases. And so with all that said, how is cannabis use disorder defined? Per DSM-5, it's defined as a problematic pattern of cannabis use leading to clinically significant impairment or distress, as manifested by a 12-month period where the user meets at least 2 out of a list of criteria. There's modifiers for mild, moderate, and severe, depending on how many of the criteria are met, as follows. If it's used in larger amounts or over a longer period than intended, if there's a persistent desire or unsuccessful efforts to cut down or control cannabis use, if there are strong cravings or desires to use, if recurrent use results in failure to fulfill major obligations at work, school, or home, if there is continued cannabis use despite social or interpersonal problems caused by or exacerbated by cannabis use, if the cannabis is used in physically hazardous situations such as driving or operating heavy machinery, if use is continued despite knowledge of problems it's causing either physically or psychologically, and if there's tolerance or withdrawal. And tolerance here is defined as a need for markedly greater amounts to achieve intoxication or the desired effect. Now, there is a characteristic cannabis withdrawal syndrome which the user may try to avoid by continuing to use. This cannabis withdrawal syndrome was a new addition from DSM-4 to DSM-5, and it's defined as 3 of the following within 1 week of stopping cannabis use. There's cravings, irritability, nervousness or anxiety, increased aggression, restlessness, increased anger, sleep difficulty and strange dreams, depressed mood, decreased appetite, and also physical symptoms, which may include sweating, tremor, headaches, and GI upset. Symptoms typically begin within 24 to 72 hours and last 1 to 2 weeks, although the sleep disturbances can last much longer. It's not possible to guarantee whether a user will experience withdrawal symptoms or not, but it is related to the frequency and intensity of use. Withdrawal occurs in about 1/3 of so-called regular users, and then among heavier users, it's anywhere between 50 to 95%. And another study demonstrated that daily users had a prevalence of cannabis withdrawal that was double the rate of less than daily users. So even if this withdrawal is not dangerous like alcohol withdrawal or not as severe as opioid withdrawal, it can still cause significant distress that makes it hard to quit. So now let's talk about definitions and the pharmacology. The term cannabis itself refers to the plant material, of which there are a few varieties. Indica and sativa are the relevant varieties that are used. Ruderalis has low THC content and is rarely used recreationally. Cannabinoids are compounds that act on cannabinoid receptors. Phytocannabinoids come from the cannabis plant, and there's over 140 of them. But the most important ones are delta-9 THC and cannabidiol or CBD. We'll just call them THC and CBD as they're commonly called. There are synthetic cannabinoids. Some of these, like dronabinol and nabilone, have medical uses for nausea or appetite. Others, like spice, are used recreationally and have no medical benefits. And then we have our own endogenous cannabinoids such as 2-AG and anandamide. There are other less relevant cannabinoids. Delta-8 THC is similar in effect to delta-9 THC, but less potent and present in far lower amounts. 11-hydroxy THC is a psychoactive metabolite of delta-9 THC. Cannabinol is marketed as a sleep aid, and it's sold recreationally, but it hasn't really been well studied. So we have an endocannabinoid system. These CB1 and CB2 receptors were discovered before the endocannabinoids were discovered. And they were given those names because the exogenous cannabinoids would bind to them. And 2-AG and anandamide are two of the more well-known endocannabinoids, but there are hundreds of these. Our natural endocannabinoid system has receptors widely distributed throughout our body. Under normal circumstances, the endocannabinoid system is thought to be involved in CNS development, synaptic plasticity, and response to endogenous and environmental insults. They're also known, these endocannabinoids are known to regulate the release of neurotransmitters, including dopamine and serotonin. This diagram attempts to show where the CB1 and CB2 receptors are most concentrated, but as you can see, it's quite messy. And that's because these receptors are everywhere in the body. Generally, we can say that CB1 receptors are primarily found in the brain and spinal cord, while CB2 receptors are primarily found in the periphery, particularly in the lymphatic and immune system. But both the CB1 and CB2 receptors can be found in the brain, spinal cord, and periphery, and generally all throughout our body. So what happens when exogenous cannabinoids are introduced? On the far right diagram, you can see that delta-9 THC, which is just labeled THC here, is a partial agonist at both CB1 and CB2 receptors. This activity at CB1 is what's going to give many of the notable effects of cannabis intoxication, including the high, but also the potential for psychosis. CBD, on the other hand, is an antagonist at the CB1 receptor and a negative allosteric modulator at the CB2 receptor. So the THC component can cause psychosis in addition to the usual effects of cannabis intoxication, but the CBD component may act as a buffer against some of the harmful effects of THC, particularly psychosis. And the effect of CBD on the CB2 receptor is thought to be responsible for its anti-inflammatory effect. And clinical studies have shown that CBD can reduce the level of pro-inflammatory cytokines like TNF-alpha. On the second graph from the left, you can see CBD acting as an antagonist at the GPR55 receptor. And this is thought to be part of the mechanism by which CBD acts as an antipsychotic buffer against the pro-psychotic effects of THC, and also how CBD can have anticonvulsant properties. On the far left, you have CBD acting as an agonist with the serotonin 1A receptor and also the TRPV1 receptor. CBD agonism at these receptors has been theorized to be responsible for an anxiolytic effect and an analgesic effect. And a question one might have is, how do the endogenous cannabinoids such as 2-AG and anandamide interact with these receptors? And the short answer is that it's complicated. They're typically low efficacy agonists at CB1, but in some situations they can be antagonists at CB1. And THC as a partial agonist is not simply overloading the CB1 receptor any more than the endogenous cannabinoids would. So again, it's complicated. An exception to this would be spice, which is a synthetic cannabinoid that is a full agonist at CB1 and has 10 to 100 times the potency of regular cannabis. And without any CBD component to buffer the full agonism at CB1, with spice you get more severe effects, including the psychosis. So let's talk about what happens acutely when cannabis is used. The effects of THC can be correlated to the areas of the brain with higher concentrations of CB1 receptors. The primary mood effect is euphoria or getting high. This is related to the binding of THC at CB1 receptors in the basal ganglia. You get release of dopamine from the nucleus accumbens. This gives it the high and also the reinforcing mechanism of many other drugs of abuse. Some people think that cannabis is not addictive, but it definitely is addictive. The anxiety and paranoia come from the action of THC at the amygdala. Motor impairment includes slowed reaction time and reduced coordination, and this can be attributed to actions at the basal ganglia as well as cerebellum. Actions in the cerebral cortex can relate to the cognitive impairments, including impaired executive function and judgment. Users can have difficulty planning and solving problems, and they might make risky decisions. Perceptual changes occur where users may find that music is more stimulating, colors may seem more vivid, and time may feel slowed down. Actions at the hippocampus can interfere with short-term memory and learning. And the appetite increase from cannabis use is probably related to the effects of the hypothalamus. There's also a vasodilatory effect, which causes conjunctival injection. And then there's tachycardia, which is usually transient and also occurs with an increase in blood pressure. This is thought to be due to stimulation of the sympathetic nervous system. And the tachycardia theoretically could be dangerous in patients with untreated serious heart conditions. And so all of these varied effects occur due to how densely CB1 receptors are distributed throughout the brain. It's important to understand that THC can stick around for a while and still cause impairment. On the figure on the right, you can see the distribution of THC throughout the body after administration. If you look at the curve for the brain concentration, you'll see an early peak concentration of about 30 minutes, which is the acute intoxication. But you'll see that there's still a good amount of THC in the brain at 24 hours. It's highly lipophilic and gets sequestered in the fat where it can stay up to a month. And then it's still being released back into the bloodstream over time. And so this has implications, particularly when you consider that cannabis intoxication interferes with motor coordination and executive function, like handling complex tasks. And there was a study in 1991 of skilled pilots who happened to be regular cannabis users, where they predictably did worse on a flight simulator after a 20 milligram dose of THC, but they also did worse 24 hours later. The graph on the bottom left there shows their decrement scores over time, with the dotted line being after using cannabis. Higher decrement scores are worse performance. So you can see clearly that even 20 to 30 hours later, there's a significant gap in performance. And what's interesting here is that the pilots didn't even perceive that they were impaired at the 24-hour mark. So clearly the effects of cannabis can last for a while, and clearly you don't want your pilot to smoke before getting on the plane, but you also don't want them to smoke the day before either. So let's talk about some of the long-term effects of regular cannabis use. There is evidence that long-term cannabis users can have cognitive impairments that last years after the last use. Whether these impairments are permanent after sustained abstinence is less clear. Higher executive functioning is most compromised. These users may have difficulty completing tasks, whether at school or work. They will often have deficits in short-term memory, attention, and concentration. And we know that the risk is most pronounced for those who begin at a young age. The frontal lobe is still undergoing development through age 25. And since there are numerous CB1 receptors in the frontal lobe and throughout the brain, the introduction of exogenous cannabinoids during this period can disrupt normal development. Studies have shown loss of between 6 to 8 IQ points in adolescent cannabis users. One study showed that this persisted into the late 30s. And another study has shown changes in the cortex, including thinning of prefrontal cortex material. This is all dose dependent. So those who start younger and smoke more frequently have a greater degree of deficits. The term amotivational syndrome was first used in 1968 as longtime users of marijuana were noted to have low motivation, apathy, and a general reduction in pro-social goal-oriented activity. It was described as, quote, diminished desire to work or compete. A 2018 study of 505 college students tested this marijuana amotivational syndrome by comparing measures of initiative, effort, and persistence, and found that marijuana users predictably had lower scores on initiative and persistence, whereas alcohol or tobacco use did not affect those scores. And in terms of lasting neuroanatomical changes, we've seen reduced hippocampal volumes. A study just published in the American Journal of Psychiatry last month demonstrated reduced bilateral hippocampal volumes at midlife in long-term cannabis users. These long-term cannabis users also had memory deficits, decreased IQ, slower processing speed when tested at midlife, defined as age 45. So probably the biggest concern with cannabis use is the association with psychosis and schizophrenia. Numerous studies have shown this association with varying numbers to quantify the strength of the relationship. It's estimated that cannabis users have a 2 to 3 times increased prevalence of psychosis compared to non-users. Daily cannabis users have been shown to have a 3.2 times increased risk of first episode psychosis compared to non-users. And a large study out of the Netherlands in 2002 followed 4,000 people without psychosis at baseline, with 1 year and 3 year follow-up periods, and found that those who used cannabis at baseline were 3 times more likely to have psychotic symptoms at follow-up. And just like with the risk for cognitive deficits, we know that the risk of psychosis is higher among those who begin younger in adolescence. The risk is also dose dependent, where a greater frequency of use and use of higher potency cannabis, which is defined as a higher THC percentage, have been shown to increase the risk for psychosis. There's also genetic risk factors where cannabis likely increases the risk that psychosis is expressed in someone who's genetically predisposed, and can precipitate their first psychotic episode at a younger age, which carries a worse prognosis. Among the acute substance-induced psychoses, cannabis-induced psychosis has been shown to have the highest conversion rate to schizophrenia, with various studies estimating it between 34 to 47%. And a study out of Denmark published last year showed that the population attributable risk fraction for cannabis use disorder and schizophrenia increased from 2% in 1995 to 8% after 2010. The population attributable risk fraction is the proportion of the incidence of a disease in a population that is due to an exposure. So in this case, we had a 4-fold increase in the cases of schizophrenia that could be attributed to cannabis use. And this increase occurred during a period in Denmark where the prevalence of cannabis use was increasing, and also the THC content of cannabis in Denmark was increasing. And increasing THC or increasing potency, meaning more THC content, is an important factor in considering the relationship between cannabis use and psychosis. We've had a steady increase in THC content over the years. In the 60s and 70s, someone might get 1 to 3% THC, and by the 80s and 90s, they were now smoking up to 20%. With the extraction of resin or oil, these percentages are much higher. And so what this means is that information and ideas about the effects of marijuana use from the 60s and 70s may already be outdated for a lot of modern users. This chart shows the percentages of THC and CBD in cannabis seized by the DEA from 1995 to 2019. The red line is THC and the blue line is CBD. The THC percentage has gone up from 4 to 14%. And the CBD percentage is about half of what it was in the early 2000s. What's interesting is that it looks like in the late 90s, there was an effort by the growers to increase the THC content. And then in the late or the mid 2000s, they also started decreasing the CBD content, which has only recovered a little bit in the last few years. And this THC to CBD ratio is important, since we know that the THC is the component that gives the high, but also increases the risk for psychosis, while the CBD component might buffer the risk. So the ratio in the cannabis that's out there in the public has flipped in the wrong direction in terms of risk for psychosis. So why do we have more THC and lower CBD content in the cannabis plants now? It's probably a reflection of what the customer wants. A 2017 survey of dispensaries in Colorado found that the most popular strains ranged from 17 to 28% THC. And for regular users, they end up developing tolerance and going to even more potent methods. You may have heard of dabbing. And so that's the use of concentrated butane hash oil, where butane is used to basically blast the marijuana and get a highly concentrated extract. And these concentrates have different forms and names like wax or shatter. And some of these can have upwards of 90% THC. And so whether cannabis use is an independent risk factor for development of schizophrenia in all people, not just those genetically at risk, is still debated. Some evidence suggests correlation rather than causation. However, this table shows a list of studies since 2015 that demonstrate some association between cannabis and development of schizophrenia. They list the Hills criteria, which are satisfied by that particular study. And the Hills criteria are a set of 9 principles that are used to identify a causal relationship between an environmental factor and an outcome. Strength refers to the effect size. Biological gradient refers to a dose-dependent relationship. Temporality means that the exposure happens before the outcome. And specificity refers to how well you can eliminate confounding factors. Plausibility and coherence refer to having a reasonable mechanism for the cause and effect. And looking at the list of psychoses, or list of studies, there's quite a bit of evidence that cannabis independently increases risk for psychosis. Another interesting study in 2020 showed that giving delta-9 THC intravenously to healthy volunteers could transiently induce both positive and negative symptoms of schizophrenia. And this would support the idea that cannabis can be directly responsible for development of psychosis, and that it's the THC component that's involved. There have been arguments about the cannabis itself causing schizophrenia, and these have focused on genetic studies such as genome-wide association studies in cannabis use in schizophrenia. And the arguments are that those who are predisposed to schizophrenia are also predisposed to using cannabis, and that there might be schizophrenia-related mechanisms that cause the cannabis use. The authors of these studies believe that evidence suggests that genetic risk variants for cannabis use disorder do increase the risk for schizophrenia, but that it's not due to the cannabis use itself. Overall, this is a very complex topic. It's not fully settled. There's plenty of good evidence for association and causation, but there's also evidence that this is correlation rather than causation. So how does cannabis use affect those with bipolar disorder? Patients with bipolar disorder are more likely to use cannabis and develop cannabis use disorder compared to the general population. And those who use typically have worse clinical outcomes. They have been shown to have a greater severity and duration of mania, increased rate of recurrence of mania, and increased risk for rapid cycling. And cannabis use is associated with an earlier age of onset of bipolar disorder. Heavy cannabis use might trigger the first episode of mania. And overall, the available evidence shows that cannabis use generally has a negative impact on the course of bipolar disorder and should probably be avoided. And what about cannabis use in unipolar depression? There is some evidence that individuals who use cannabis are at increased risk for depression, and that having depression also increases the risk of developing cannabis use disorder. But the overall evidence for cannabis being an independent risk factor for developing depression is not as clear as it is for psychosis. Longitudinal studies of people without depression have demonstrated that cannabis users are 4 times more likely to develop depression. But this is a correlation and not necessarily a causation. Certain features of depression, such as anhedonia and sleep disturbances, may be more prominent among cannabis users. Some studies have shown that in patients with both depression and cannabis use disorder, stopping cannabis use improves the symptoms of depression. What is well known, however, is that cannabis use disorder is associated with worsening functional status, such as unemployment or lower income, greater need for socioeconomic assistance, and overall decreased life satisfaction. All of these are stressors which could increase risk for depression. And various studies within the last 5 years have suggested that cannabis use and depression share genetic risk factors, which may suggest that cannabis is not independently causing depression. Overall, there's certainly evidence that's suggestive of a link between cannabis use and depression, but we can't necessarily say that cannabis use will lead to development or worsening of major depression. This will be a little more controversial, but cannabis use has been associated with increase in suicidality in multiple studies. A 2017 multi-site VA study of over 3,000 veterans found that cannabis use disorder was significantly associated with both current suicidal ideation and lifetime history of suicide attempts compared to veterans with no lifetime history of cannabis use disorder. And this significant difference continued even after they adjusted for confounding factors like sex, comorbid psychiatric conditions, other drug use, history of childhood abuse, and combat exposure. And a study published last year by the National Institute of Drug Abuse showed an increased risk of suicidal ideation planning and attempts in the 18 to 35 age group. They used data from the National Survey on Drug Use and Health collected between 2008 and 2019, which had a huge 288,000 adult sample size. And the increased risk of suicidal ideation among cannabis users occurred whether they had major depression or not. This is also dose dependent, where more frequent use was associated with a greater increase in rate of suicidal ideation. However, some other studies have not found an association between cannabis use and increased suicide risk. So this is still a topic of debate where the evidence is not quite as robust as it is in psychosis. With regards to the link between cannabis use and anxiety disorders, it's hard to come to a clean conclusion. Most studies that have been done are observational or retrospective analyses of large databases. There's an association between cannabis use and anxiety disorders, but it's not clear that there's causation. Some studies have shown an association with cannabis use and social anxiety disorder and agoraphobia. It's possible that this is all due to confounding factors that might be commonly shared between the cannabis use and anxiety disorders. Another wrinkle here is that many of these studies are looking at cannabis, which includes a variable THC component. And as we've talked about, there's an increasingly higher THC versus CBD component content in the cannabis being sold today. And anecdotally, we've heard that using a small amount of marijuana will help with anxiety, while using too much can cause paranoia and panic. And this has actually been demonstrated in some studies. One study in particular used nabilone, which is the synthetic THC, where at low doses it was an anxiolytic, and at higher doses it increased anxiety. Overall, the evidence is not conclusive, but there's not really strong evidence yet that cannabis use is directly implicated in the development of anxiety disorders. When you compare the evidence base for depression versus anxiety, it looks like the evidence for cannabis implication in depression is a bit stronger than in anxiety disorders. Cannabis has been increasingly used by patients in an attempt to self-medicate PTSD symptoms. However, the majority of the available evidence suggests that harm outweighs any benefits. There have been observational studies showing an association with cannabis use with increased symptom severity in PTSD, poorer mental health outcomes in general, and suicidal ideation. Some patients with PTSD report using cannabis for sleep disturbances, but some studies show that it leads to poorer sleep quality, and sleep symptoms eventually improve after quitting cannabis use. There have been some studies of using various forms of cannabis to treat PTSD. And while some small studies have shown positive results, others have not shown benefit. One of the studies out of Canada using nabilone showed a reduction in nightmares. But overall, the evidence for benefit in PTSD is minimal at this point and probably outweighed by evidence showing harm. So what about insomnia? Many cannabis users say that it helps them sleep. So there must be some evidence for that anecdotal claim. And looking at the studies, it's fairly limited and with mixed results. The consistent finding is that cannabis use is actually a risk factor for insomnia. So some studies have shown decreased REM sleep, while others have shown increased REM or no change. Some studies have shown decreased sleep latency, while others have shown an increase or no change. So overall, the evidence is not too strong that cannabis treats insomnia effectively. So this table is from a 2019 paper out of the University of Toronto, and it summarizes the evidence pretty well. If you look at the left column labeled therapeutic benefits, you'll see that across the board, there's really no good evidence that cannabis helps any of these psychiatric conditions, except maybe sleep dysfunction and PTSD based on that one study. If you look at the middle harms column, you'll see that the evidence is strongest in schizophrenia, where there's a strong dose-dependent relationship with poorer outcomes. For major depression, the evidence is suggestive of harm, especially with adolescent onset of use. And with bipolar disorder, they say there's no association with harm, but also equal findings with statistically insignificant associations. So this is where we already begin to have some uncertainty. But they've summarized the evidence for cannabis use in PTSD as minimal evidence of harm, but with unclear long-term effects. And for generalized anxiety disorder, they're reporting that the evidence is equivocal, with maybe a positive association between cannabis use and anxiety disorders. So I think what's tricky about all of this is that there's not black and white answers for how harmful cannabis is in many of these cases. It's still a Schedule I drug federally, which makes research more difficult and which limits the amount of evidence to draw upon. So a question one might have is why some cannabis users who are self-medicating feel that it's beneficial, despite the evidence not really supporting that belief. What's likely happening is that there's temporary relief from negative mood symptoms when somebody uses cannabis. It provides euphoria when THC binds the CB1 receptor in the nucleus accumbens, releasing dopamine. For someone who's experiencing a negative affective state, whether it's depression or anxiety, the euphoria is definitely an improvement, but it's temporary. And so the brain's reward pathways light up, and this positive relationship gets formed with cannabis. And with enough use, our body's own endocannabinoid system gets downregulated. We have natural negative feedback loops to maintain homeostasis. We know that CB1 receptors are downregulated in regular cannabis users. So if somebody is habitually using cannabis, they will have a hypoactive endocannabinoid system that's less effective at regulating mood symptoms, sleep, stress, etc., compared to a non-user. And so not only will they have a lower mood baseline for physiologic reasons, they may lack non-drug coping skills to deal with negative emotions. And because withdrawal can start around 24 hours, a daily cannabis user might be fighting off withdrawal symptoms every night, which can look like depression, anxiety, and insomnia. And during cannabis withdrawal, there is a decrease in mesolimbic dopamine function, and that motivates the user to go get high again. So generally, the evidence points to cannabis being addictive like other drugs of abuse. So let's talk about treatment options. First of all, it's important to know that there are no FDA-approved medications for cannabis use disorder. In terms of therapy, the approaches are similar to other substance use disorders. So there's, of course, CBT, which has been shown to be helpful in treating substance use disorders, including cannabis use. There's motivational enhancement therapy, or MET, which is based on motivational interviewing principles. This is typically brief, something like 4 to 6 sessions, and it involves guiding the patient through stages of change, such as pre-contemplation, contemplation, preparation, action, maintenance, and relapse. The therapist's role here is to help the patient identify their own reasons for making a change, what the benefits will be, and how to avoid a relapse. Contingency management is based on operant conditioning and positive reinforcement. So essentially, it's providing a reward to the patient for continued abstinence. In practice, this might consist of regular urine drug tests, which the patient has to pass in order to get some kind of low monetary value reward. This could be a gift card, voucher, or entry into a prize pool of some kind. In terms of medications, there's insufficient evidence overall to recommend for or against the use of any medications in treating cannabis use disorder. Many medications have been studied with mixed results. Some medications primarily help the withdrawal symptoms. Others may help with cravings in the early period and theoretically would help prevent relapse. For withdrawal symptoms, you're providing supportive care for symptoms as you would an opioid withdrawal. Zolpidem has been shown to help with insomnia, but of course, that may not be the best option due to the side effect profile as well as risk for dependence. Nitrazepam is a benzodiazepine not available in the US. And more likely, you'd be better off using medications such as trazodone or hydroxyzine. Mirtazapine can help with sleep, as can Seroquel. And these would likely help with appetite as well, which can be reduced during the withdrawal period. Clonidine may be used and may be helpful with the autonomic symptoms experienced during withdrawal. And in terms of medications to help with cravings and to prevent relapse, there's a few that have been studied. Topiramate has at least one study in 2016, which was in adolescents and young adults, where it was shown to help reduce the amount of use compared to placebo, but it didn't change the rates of abstinence. And then gabapentin has had some evidence that it can be useful. A 2012 study showed that gabapentin helped with cravings and reduced cannabis use as measured by self-report and urine measurements. N-acetylcysteine has had some studies showing its efficacy in treating cannabis use disorder, although the evidence has been mixed. And then naltrexone has had mixed evidence, but there's been at least one study from 2015 that showed that maintenance naltrexone use might reduce cannabis use, as it reduced the user's self-reports of the positive effects from cannabis. So regarding the synthetic cannabinoids, theoretically, cannabis replacement with CB1 receptor agonists might work similarly to how opioid replacement therapy works. So however, the evidence is primarily showing benefit in treating withdrawal symptoms with less clear benefits after that period. Dronabinol or Marinol is a synthetic version of delta-9 THC that partially agonizes CB1 receptors. It's primarily used for appetite, but it's been shown in multiple studies to be helpful for withdrawal symptoms. However, studies have not shown that dronabinol actually helps cannabis users quit. There were some inconsistent evidence that at higher doses, it might blunt some of the positive subjective effects of smoking cannabis. And so the idea was that it essentially could block some of the euphoria or high from smoking, but it hasn't been shown to actually help them quit. It does theoretically have some abuse potential, but it's actually not been shown to have any abuse potential, as it's slow onset and long duration of action, which produces minimal euphoria. Nabilone is another synthetic version of delta-9 THC that has stronger activity at the CB1 receptor than dronabinol. It may be more promising as a long-term treatment for cannabis use. There's been at least 2 studies that have shown some benefit for nabilone in treating cannabis use disorder. A 2013 study showed that it improved withdrawal symptoms, minimized cravings, and helped prevent relapse. It does theoretically have a higher abuse potential than dronabinol, as it has a stronger CB1 agonism, but this hasn't actually been shown to be a common occurrence due to, once again, being long-acting with slow onset. Users in these trials have reported very little subjective effects, such as euphoria or high, from taking nabilone. Another interesting medication is nabiximols, a brand name Sativex, which contains a combination of a 1-to-1 ratio of THC to CBD in a spray formulation, but it's not approved or available in the US. A 2019 study of 128 patients found that a 12-week course of Sativex reduced the illicit use of cannabis compared to placebo. But so far we don't have much further evidence, and the use is primarily in Europe and Canada for spasticity in multiple sclerosis. Many other medications have been tried with either limited or negative results. While Buterin has been studied and in multiple trials not found to be helpful in treating cannabis use disorder. The idea was that there may be some similar mechanism in helping users quit cannabis like it does to help quit smoking. But so far, the evidence hasn't shown this to be the case. There's been at least 2 studies with SSRIs, including Lexapro and Prozac. Neither showed any benefit in reducing cannabis use. Effexor was tried and didn't show any benefit as well. Mirtazapine did show some benefit for insomnia, but didn't help reduce cannabis use. Buspar has had mixed and inconclusive results, and on some of the treatment algorithms for cannabis use, I've seen it listed, and others say it has no benefit. Lithium was briefly studied and showed some possible benefits in treating withdrawal in older studies, but in newer studies, that benefit could not be reproduced. Valproic acid was studied, and it really didn't do much benefit at all. Users felt that they were cognitively worse off, they were more irritable, they had poor adherence when using the medication, and it also didn't help them quit cannabis. As far as antipsychotics go, Seroquel has shown benefit during the withdrawal period, but has mixed results, with at least 1 study showing increased cravings for cannabis and increased relapse rates. Zyprexa and clozapine have been studied in patients with psychotic disorders who use cannabis, and it's not been shown to have any effect on reduction in cannabis use. A CB1 receptor antagonist, rimonabant, was being studied, but this was stopped due to increased suicidality in the users. So theoretically, you might imagine a CB1 antagonist could treat psychosis, since we know that CB1 agonism can cause psychosis. However, it hasn't been shown to be an effective treatment for psychosis, and the drug was never approved for use in the United States. In Europe, it was approved in 2006 as an anti-obesity drug, actually, since CB1 antagonism suppresses appetite. But then due to the suicidality, it was taken off the markets in 2008. Now, interestingly, oxytocin has had several positive studies showing it might reduce cravings for cannabis and may help enhance the effects of motivational enhancement therapy. And the theory here is that oxytocin would enhance pro-social behavior, which would aid the therapy. The study showed that oxytocin given on the day of therapy reduces the amount of cannabis used that day, but it didn't actually reduce the amount of cannabis used overall in the days between therapy sessions. So there is some promising evidence, but not sufficient evidence, and nothing is FDA approved yet for the treatment of cannabis use disorder. So we've talked a little bit about CBD, and we know it has anticonvulsant activity, and in 2018, it was FDA approved for the treatment of seizures and a couple of forms of pediatric epilepsy, as well as tuberous sclerosis. So it's not out of the question that we could see CBD getting an indication for psychiatric disorders in the future. It makes sense theoretically that CBD might help treat psychosis since it counters the pro-psychotic effects of THC. And there actually have been some positive studies for CBD treating psychosis, but also negative studies. There was one trial out of Europe where they compared CBD to amisulpride for treating schizophrenia. And amisulpride is an antipsychotic that's primarily used in Europe, but not available in the US. And in that study, they found that CBD was as effective as amisulpride in treating both the positive and negative symptoms of schizophrenia. And the CBD was generally well tolerated and had minimal side effects. Another study tried CBD as an adjunct treatment for schizophrenia on top of antipsychotics and showed a significant improvement in positive symptoms of psychosis. However, this result could not be replicated in another study. So there's also evidence that CBD might be useful in getting cannabis users to quit or reduce their use. There was a randomized controlled trial published in 2020 in the Lancet, which showed benefit of CBD for reducing cannabis use. So there are some positive studies, but not quite enough evidence yet. And these books I put pictures of just to show the popular perception out there that CBD can treat anxiety and insomnia and chronic pain. And in looking at the evidence, there definitely are positive studies to support those claims. And mechanistically, CBD, we know, acts on the 5-HT1A receptor. And so perhaps that might be how it is an anxiolytic. There have been a couple of studies in 2019. One was a review of 6 randomized control trials that found that CBD was generally well tolerated and improved ratings of anxiety. There was another study in 2019 that showed that CBD improved anxiety and also improved sleep, but the improvements in sleep were temporary and didn't last after a month. So generally, the evidence for CBD and anxiety seems to be stronger at this point than the evidence for CBD and sleep. And then regarding chronic pain, there is some mixed evidence that CBD can be beneficial in certain types of chronic pain, like cancer-related pain. But at this point, I would say it's still to be decided, and we should be cautiously optimistic on CBD. We do know that it doesn't have the dependence potential, and we do know that it's not as addictive, and it doesn't cause psychosis. It doesn't have that euphoria. But the evidence is not quite there yet to really recommend it strongly for any condition. So to summarize the take-home points, I think before we discuss, cannabis use is definitely associated with the development of psychosis and schizophrenia. It's riskier in those who start young and have a genetic predisposition, and the risk is dose dependent. And cannabis use likely worsens psychiatric outcomes in general. And there's an association with increased suicidality, although that's controversial. Cannabis definitely can be addictive, and dependence with the characteristic withdrawal syndrome does occur. Treatment involves therapy with a combination of CBT, motivational enhancement, and therapy and contingency management. There are no current FDA-approved medications for cannabis use disorder as of yet. And last, there is some positive evidence for CBD as a treatment modality. It doesn't increase risk for psychosis and may actually be protective against it, but we'll have to stay tuned as more studies come in. And that's all I've got for today. I appreciate your attention and welcome any questions, comments, and we'll open up the floor for discussion.
Thank you, Dr. Koo, for such a well-organized and thorough presentation, and for just unpacking such a loaded subject. Yes, we'll open up the floor for questions now.
Yeah, hi, Justin.
Hey, Dr. Wong.
Hey, it's Dr. Wong. Yeah, I think I missed part of the talk. I apologize. What's a biological function of cannabinoid system, in the body, and then is it gonna be, therapeutically beneficial to manipulate that system?
So when I looked at evidence for the endocannabinoid system, I increasingly found that it's complex and really unclear and not too well known. There's evidence that it modulates neurotransmitter function, so dopamine, norepinephrine, serotonin. There's evidence that the endocannabinoid system is heavily involved in brain development, like frontal lobe development during adolescence. And then it's also involved in certain modulating affects in naturally. So for example, like the runner's high, that's an endocannabinoid effect. In terms of using endocannabinoids, using cannabinoids to actually have therapeutic benefits, I wasn't able to find anything where people are synthesizing endocannabinoids. I guess it's kind of not, there's an issue of nomenclature because endocannabinoids are natural. So the cannabinoids that are being used are primarily there's nabilone, which is the synthetic THC. There's the dronabinol, another synthetic version of THC. They're slightly different. I think the nabilone is like a genetic mimic, whereas there's a mimic at the receptors, whereas the dronabinol is an actual, and it's basically just a copy. And then there's things like the Sativex, which is a combo of THC and CBD. But essentially, aside from the CB1 receptor antagonist, the rimonabant, I haven't seen much in terms of other medications being tried to modulate the endocannabinoid system. The rimonabant, there were studies, in the mid 2000s where they were really hoping it would have some benefit because it seemed to make sense that you antagonize the CB1 receptor and you'll treat psychosis, but it really didn't work, and it really it made people have more suicides, so it was obviously immediately stopped. So really, the evidence is all new. I think from what I saw, the receptors were only discovered, I think, in the early 90s, and then the endocannabinoids themselves are the two most well-studied ones, the 2-AG and the anandamide, were only discovered, I think, in the mid 90s. So really, it's a huge and complex system. It's all over the body. It's in multiple organs, but really, in terms of what it's doing, specifically, it's hard to say. We know it's involved in immune function. We know it's involved in a lot of different things, and it seems to be everywhere. But hopefully that answers your question. I think the takeaway that when I was reading these studies, the takeaway I got was that there's so little information that's clear about what the endocannabinoid system does, but we know it's involved in a whole heck of a lot, and that we know that when you introduce exogenous cannabinoids for a long period of time, you're downregulating and affecting, your own endogenous endocannabinoid system, and so that can have long-term effects, and so it's pretty scary.
And do you want to make some comments about spice? How's that different from CBD and the THC?
Sure. So it was synthetically made in a lab, I think in the 60s or 70s. Obviously, it wasn't intended to get high for users to get high, but essentially, chemically I think there's over 100 of these. They're chemically different structures, but they all bind the CB1 receptor with increasingly or exceedingly high potency. So, and they don't have any CBD components. So, essentially, what you get is 10 to 100 times the potency at the CB1 receptor. And so, recreationally, the user is hoping to get a stronger high, right? Euphoria and all of that, but they're going to get the negative psychosis and the negative effects as well. And theoretically, this could also be why, characteristically, if you see somebody coming with spice, they have even more memory impairment. They may be like almost dissociative. They may have more movement impairment, right? They may look like zombies. And if you think about what the agonism at the CB1 receptor actually does, it's hitting the cerebellum, it's hitting the basal ganglia, it's hitting the hippocampus. It makes sense that it's like a more severe version of all the negative things, right? And so that, when I was researching, that is what is really concerning about, in my opinion, about the legalization. Although I'm in favor of it generally, but you have to be careful with the fact that people are going to develop tolerance, and they're going to increasingly enjoy the euphoria of the CB1 agonism, and they're going to increasingly want to seek out a higher high, so to speak. And so once you get to the more concentrated THC, where you have higher potency, it's like you're on a spectrum or a gradient between the increasing potency, where at some point are we going to bridge the gap to where people are recreationally using like a weaker spice. So,
Dr. Good, I did have a question in the chat for you from Dr. Good, just asking if you found any information about specific genes that contribute to the likelihood of developing schizophrenia with cannabis use.
I did. I will confess I don't remember the names right off the top of my head. There were certain genetic risk variants that were associated with both. They predicted the development of cannabis use disorder and schizophrenia, and so that's what these genome-wide association studies were trying to suss out is it a bidirectional relationship? You know, does the cannabis essentially does the association work both ways, so to speak? And so that was the argument by the authors of the more recent genetic studies, that it is probably more genetic related rather than cannabis itself causing the schizophrenia. But you know, there's been other studies that show, like that table I showed with the Hills criteria. There's other studies that argue pretty strongly that it's causative. And I would say it's complex. I would say that you can't say 100% one way or the other, that only people that have those certain genetic risk variants are going to develop psychosis or schizophrenia with cannabis use, because when they gave the IV THC to the users or to the totally healthy people, they predictably got psychotic symptoms. It was temporary, but they predictably got psychotic symptoms. So whether cannabis use predisposes for schizophrenia in everybody, I don't know, but it certainly seems to be, if you give enough in a strongly concentrated form, it certainly can cause psychosis.
Dr. Q, what have you also noticed about cannabis use and cannabis use disorder as it pertains to the COVID-19 pandemic?
Well, I didn't specifically look up information related to that, but I assume it went up. You know, people are stuck at home, and so I assume substance use disorder in general went up. You know, if people are working from home and if they can get away with being higher or intoxicated on some substances, I'm sure things have gone up. But yeah, that's a good question.
Yeah, I just wanted to say you did a really nice job there, Justin. Good job.
Oh, thank you. I did have, I figured someone was going to ask about this. I didn't get into my presentation, but there's some question about the harm reduction for opioid use, like heroin users and opioid users. You know, some people say that like they want to use medical marijuana or CBD. So the evidence I found most recently is that cannabis use actually increases rather than decreases the risk for developing non-medical prescription opioid use and opioid use disorder. So the evidence is kind of against it. But in somebody that's already using opiates or has an opioid use disorder that says that cannabis is helping them come off opiates, you know, I think that's less clear. And then with CBD, there's actually been a recent study in 2019 published in the American Journal of Psychiatry, and that one actually showed that CBD reduces cravings and anxieties in people with heroin use disorder that are in remission. So this was a really interesting study because basically they gave people with CBD or a heroin use who had been, you know, abstinent for however long, they gave them a dose of CBD, and then they flashed up pictures of like drug paraphernalia, like pictures of heroin and things like that, and they're measuring you know, anxiety and cravings, and found that it actually went down after CBD administration. So overall, the evidence for CBD I'm finding is pretty promising, but limited at this point.
Thank you for your presentation.
Awesome.